Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 403 of our pharmacotherapy series, which majors in upper gastrointestinal disorders. The next clinical case reads, TJS, a 58-year-old, 110 kg man was admitted to the medical ICU for severe necrotizing pancreatitis identified on abdominal computed tomography. The patient was immediately made nothing by mouth and started on imipenem C Listatin 1000 mg IV piggyback, abbreviated as IVPB, every 6 hours. He was given hydromorphone 1 mg IV every 3 hours as needed for pain. He subsequently exhibited shortness of breath on his third day after admission. He required intubation and was placed on a ventilator. A chest X-ray showed a left lower lobe infiltrate suggestive of hospital-acquired pneumonia. Antibiotic coverage was increased with the addition of ciprofloxacin 400 mg IV piggyback every 8 hours and linezolid 600 mg IV every 12 hours. He has a temperature of 103.5 degrees Fahrenheit, heart rate of 115 beats per minute, and blood pressure of 70 systolic 40 diastolic. His pertinent laboratory results at this time include the following: a WBC count of 38,000 per microliter, a hemoglobin of 13.6 grams per deciliter, a hematocrit of 40%, platelets of 150,000 per microliter, a serum creatinine of 1.3 milligrams per deciliter, a BUN of 24 mg per deciliter, an INR of 1, an APTT of 39 seconds, an aspartate aminotransferase of 292 units per liter, an alanine aminotransferase of 305 units per liter, an amylase of 508 units per liter, lipase of 624 units per liter. In addition to the antimicrobials and initiation of fluid resuscitation, the critical care team is considering stress ulcer prophylaxis. So my question to you reads, what risk factors does TJS have, if any, for stress-related mucosal bleeding abbreviated as SRMB, and is he a candidate for stress ulcer prophylaxis? Numerous risk factors have been associated with stress-related mucosal bleeding. However, a large landmark, multi-center, prospective study involving more than 2,200 critically ill patients admitted to a medical ICU identified only the requirement of mechanical ventilation, due to respiratory failure, or coagulopathy as independent risk factors for development of clinically important bleeding. Considering the cost associated with the reduction of risk related to stress-related mucosal bleeding, the authors concluded that only these two risk factors warrant the use of prophylactic therapy. Because not all risk factors impose the same level of risk, clinical guidelines and most practitioners recommend prophylaxis only when the patient is mechanically ventilated, has a coagulopathy, or when two or more of the remaining risk factors are present. TJS's risk factors include septic shock as evidenced by hemodynamic instability and mechanical ventilation. Therefore, a prophylactic regimen to reduce the risk of stress-related mucosal bleeding is appropriate. My next question to you reads: what options exist to prevent stress-related mucosal bleeding in TJS? Not all patients admitted to the critical care unit will require prophylaxis for stress-related mucosal bleeding. However, because mortality can be high in patients when bleeding occurs, evaluation of risk is of absolute importance to ensure that protective pharmacotherapy is initiated in appropriate patients. Because acid is required for mucosal injury, the inhibition of gastric acid is the primary target when pharmacotherapy is used to reduce the risk of stress-related mucosal bleeding. An intragastric pH greater than 4 is the recommended goal of therapy. Therapeutic options include the use of antacids, sucralfate, histamine 2 receptor antagonists, and proton pump inhibitors. Regarding antacids, the use of aggressive antacid therapy is superior to placebo in reducing clinically important stress-related mucosal bleeding when an intragastric pH greater than 3.5 is maintained. Although antacids are effective in preventing stress-related mucosal bleeding, their use has fallen out of favor because of difficult administration regimens, that is every 1 to 2 hours. With the continuous requirement of intragastric pH monitoring for dose titration, electrolyte abnormalities, especially in patients with renal dysfunction, diarrhea, constipation, and the potential risk of aspiration pneumonia. These issues, coupled with the fact that potent acid suppression is available in far more convenient dosage forms, have all but eliminated the use of antacids as stress-related mucosal bleeding prophylaxis. Regarding sucralfate, sucralfate is effective in preventing stress-related mucosal bleeding, but does not have an important effect on intragastric pH. Despite the fact that antisecretory therapy is preferred, sucralfate remains an available therapeutic option. Early studies suggested a reduction in nosocomial pneumonia with sucralfate when compared with ranitidine or antacids. However, a subsequent randomized trial involving 1,200 mechanically ventilated patients revealed no increase in pneumonia with histamine 2 receptor antagonists when compared with sucralfate or antacids. The usual dose of 1 gram 4 times daily can present problems within the critical care setting because of multiple daily dosing, binding of other enterally administered drugs, and occlusion of nasogastric tubes, may be reduced with suspension formulation. Other potential issues include the risk for aluminum toxicity in patients with renal failure, constipation, and electrolyte imbalances. The concomitant use of sucralfate with antisecretory therapy may reduce the effectiveness of sucralfate as an intragastric pH less than 4 is needed for conversion to its active form, which binds to the gastric mucosa. We will now look at histamine 2 receptor antagonists. Histamine 2 receptor antagonists are effective in preventing stress-related mucosal bleeding and are the most widely used for this indication. Although only cimetidine continuous infusion has been FDA labeled for the prevention of stress-related mucosal bleeding, continuous or intermittent infusions of ranitidine and famotidine are most often used for this indication. Continuous infusions have been suggested as being more effective in maintaining a pH greater than 4, but there are no data comparing these two treatment options with respect to clinical outcomes. Despite this, intermittent dosing is used more commonly than continuous infusions for the prophylaxis of stress-related mucosal bleeding. Numerous meta-analyses have evaluated the effectiveness of histamine 2 receptor antagonists for prophylaxis of stress-related mucosal bleeding. Cook et al. Reviewed 63 randomized trials and determined that prophylaxis with histamine 2 receptor antagonists was associated with a statistically significant reduction in overt and clinically important upper gastrointestinal bleeding when compared with no therapy and a significant reduction in overt bleeding when compared with antacids. A trend toward reduced clinically important bleeding was identified when histamine 2 receptor antagonists were compared with sucralfate, but this was not statistically significant. In another meta-analysis, ranitidine was shown to be of no benefit in preventing stress-related mucosal bleeding and increased the risk of pneumonia. However, neither of these meta-analyses included the large study involving 1,200 mechanically ventilated patients that compared sucralfate, ranitidine, and placebo. Despite these conflicting results, histamine 2 receptor antagonists remain a recommended option for the prophylaxis of stress-related mucosal bleeding. One shortcoming of histamine 2 receptor antagonists is that tolerance may develop within 72 hours, and thus theoretically lead to potential prophylaxis failure. Histamine 2 receptor antagonists are eliminated renally, and dosage reductions may be required in patients with renal failure. Regarding proton pump inhibitors, because of their profound ability to inhibit gastric acid secretion and lack of tolerance to their antisecretory effect, would appear to be the preferred option for preventing stress-related mucosal bleeding. However, there is very little evidence to confirm their clinical superiority to histamine 2 receptor antagonists for this indication. Numerous studies have compared proton pump inhibitors with histamine 2 receptor antagonists or placebo in critically ill patients in small populations using varied predetermined endpoints. These studies suggest that proton pump inhibitors provide greater acid suppression compared with histamine 2 receptor antagonists and are likely to be as effective in preventing stress-related mucosal bleeding. One study in 359 critically ill patients evaluated the use of immediate-release omeprazole suspension in bicarbonate given via nasogastric tube at a dose of 40 mg for 2 doses, then 40 mg per day versus IV cimetidine given as a 300 mg bolus and then infused at 50 mg per hour. Dosing was adjusted for patients with renal dysfunction. The results indicated that the proton pump inhibitor bicarbonate suspension was associated with a greater mean time of intragastric pH greater than 4 than the cimetidine infusion, but that the rate of clinically important bleeding did not differ between cimetidine, that is 6.8%, and omeprazole, that is 4.5%. The FDA considered the immediate-release omeprazole bicarbonate suspension to be non-inferior to cimetidine for the prevention of stress-related mucosal bleeding. An extremely important analysis aimed at identifying the most appropriate dose for IV proton pump inhibitors in stress-related mucosal bleeding prophylaxis was performed in more than 200 critically ill patients. This analysis included 5 different dosing approaches of IV pantoprazole intermittent infusions, 40 mg given every 8, 12, or 24 hours or 80 mg given every 12 or 24 hours, compared with C-metadine given as a 300 mg IV bolus immediately followed by a 50 mg per hour continuous infusion. The patients received a minimum of 48 hours of therapy with a maximum of 7 days. In all the study arms, pH control was achieved, defined as intragastric pH equal to or greater than 4. However, in all the pantoprazole arms, pH control continued to improve from day 1 to 2, whereas a decline was noted in the cimetidine group, suggesting the occurrence of tachyphylaxis. No upper gastrointestinal bleeding was noted in any patient during the trial, regardless of treatment group assigned. The conclusions of this study demonstrated that patients may have adequate pH control with an initial IV dose of pantoprazole 80 mg followed by 40 mg IV every 12 hours. Finally, a recent meta-analysis that included 14 studies totaling approximately 1,700 patients evaluating the efficacy and safety of proton pump inhibitors compared with histamine 2 receptor antagonists demonstrated a statistically significant difference between the two options with respect to the important endpoints of overt or clinically important bleeding. There were no differences with regard to mortality or incidence of pneumonia. The incidence of nosocomial pneumonia in patients receiving proton pump inhibitor therapy undergoing cardiothoracic surgery has been evaluated in 2 retrospective cohort studies. Patients receiving proton pump inhibitors were at an increased risk for developing pneumonia even after data adjustments for various risk factors. Numerous alternative administration options exist for patients in the critical care setting who cannot take medications by mouth, have nasogastric tubes in place, or have difficulty swallowing. Proton pump inhibitors are becoming first-line therapy for the prevention of stress-related mucosal bleeding, but additional studies are needed to confirm the most effective dose and route of administration in order to obtain optimal clinical outcomes in patients at risk of stress-related mucosal bleeding. The use of early enteral nutrition that is initiated within 48 hours of admission to the ICU has also been evaluated as a means of prophylaxis against stress-related mucosal bleeding. This was demonstrated in a meta-analysis of 17 studies, which suggested that patients who require enteral tube feedings may not require additional forms of stress-related mucosal bleeding prophylaxis and may also have a reduced risk of pneumonia or death when compared with patients receiving a histamine 2 receptor antagonist-based stress-related mucosal bleeding prophylaxis regimen. This meta-analysis, however, was only hypothesis generating and should be interpreted with care until a large controlled study is available to confirm these findings. TJS has been started on famotidine 20 mg IV every 12 hours. My question reads: how should this pharmacotherapy be monitored for safety and efficacy? The famotidine dose should be adjusted to maintain an intragastric pH greater than 4 and should be based on severity of the patient's illness, renal function, and intragastric pH measurements. The intragastric pH can be determined with an indwelling probe or by measuring the pH of nasogastric aspirates. The patient should be monitored for signs of bleeding, e.g., presence of blood or coffee ground material in nasogastric aspirates, hematemesis, hematochezia, or melena, hypotension, reductions in hemoglobin or hematocrit, and thrombocytopenia. During the next 6 days, TJS improves and is subsequently removed from mechanical ventilation and transferred to the medical ward. He is now able to eat normally. So my next question to you reads: should TJS be continued on stress-related mucosal bleeding prophylaxis? Patients receiving prophylaxis for stress-related mucosal bleeding should be evaluated for the continued presence of risk factors. As the patient improves, the risk factors should in turn be reversed, and the need for stress-related mucosal bleeding prophylaxis should diminish. Factors such as extubation, correction of coagulopathies, discharge from the intensive care setting, and the ability to take oral feeding advocate the discontinuation of prophylaxis. Numerous studies have suggested that up to 54% of patients were ordered stress-related mucosal bleeding prophylaxis outside the ICU setting and without a compelling indication. Erstad and colleagues surveyed 153 institutions within the United States, and found that in 65% of the hospitals, more than 25% of patients remained on stress-related mucosal bleeding prophylaxis after discharge from the ICU. This can lead to increased costs, the potential of the patient being discharged on medication for which there is no indication, and future potential adverse effects from the medication. Because TJS does not possess any risk factors for stress-related mucosal bleeding, famotidine should be discontinued at this time. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arora, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 404.